Aditya, let's turn a little bit to the metastatic triple-negative setting. Say a few words, if you would, about some of your general approaches to chemotherapy in the metastatic setting, sort of outside of clinical trials. And what do you think about the data that Hope Rugo updated us at San Antonio with the Nab-Paclitaxel Bev versus the Paclitaxel Bev, in the triple-negative subset?
So if I'm seeing a patient with metastatic triple-negative breast cancer, I think the first branch point is whether it's de novo metastatic disease versus someone who has disease recurrence after prior adjuvant or neoadjuvant therapy. If someone has de novo metastatic disease, the choices are essentially taxanes versus platinum, and we can use the TNT trial data to guide whether we should use a taxane versus platinum. And as a reminder, the TNT trial showed that there was no real difference between the use of a platinum versus a taxane, except for the germline BRCA group. So unless someone has a germline BRCA positive tumor, I would probably start with a taxane. Taxanes do work in breast cancer, including triple-negative breast cancer, are better tolerated. So I tend to use a taxane first. And then upon disease progression, you have various options one could consider. You could consider a platinum. You could consider eribulin. You could consider an anthracycline. So these are all the options that I would essentially sequence when seeing a patient with metastatic disease. On the other hand, if I have a patient who has disease recurrence within a short period of their adjuvant chemotherapy or the neoadjuvant chemotherapy, which is usually, that patient has usually seen an anthracycline plus a taxane, then I would be more inclined to use platinum as a first-line agent, and then upon disease progression on platinum, consider eribulin or some of the other chemotherapy agents. But I would also emphasize that for metastatic triple-negative disease, and actually for breast cancer in general, we tend to think of clinical trials. And if there is a clinical trial of a platinum agent plus something else, or one of these novel ADCs or targeted therapies, I would tend to consider that as well.
Yeah.
Now, as far as the differences between the various agents, I think Paclitaxel versus Abraxane and the data that Hope presented essentially shows that Paclitaxel is a good agent. The Abraxane is similar to Paclitaxel. Maybe slightly inferior in the metastatic setting, tends to be associated with more adverse events, but that's splitting hairs. And if I have a patient who has diabetes or there's concern of hypersensitivity to taxane, I would feel very comfortable using an Abraxane. And also considering using Abraxane with immunotherapy, because you don't have to worry about the use of steroids. The ongoing trials that are using PD-1 inhibitors in the metastatic setting are using Abraxane as a backbone. So that is something that I would consider.
How about you guys? What do you do metastatic-wise from the approach chemotherapy, but also the NAB and the Paclitaxel question?
Sure. I mean, I think I would echo a lot of what Aditya has said. And for our patients with TNBC, they may have very well received 5 agents already in the early stage setting between anthracycline, taxane, platinum, capecitabine. So a patient with first-line metastatic triple-negative breast cancer is not the same as first-line ER-positive metastatic breast cancer. They're already potentially heavily pretreated. And I think it's critical to mention, as you really started this afternoon with, is getting tissue at that time of metastatic disease, at diagnosis, and really doing the tumor genomic profiling on that material. Because after exposure to all of those drugs, we'd like to see what is there. Confirm we're still talking about triple-negative breast cancer, hopefully have a mutation that's potentially targetable. So I think a clinical trial in the first-line setting is very appropriate for these patients. I do find that I move eribulin up sooner than perhaps in the Embrace trial that was previously published. But I really start to look for non-chemotherapy options. And one of my early branch points are, what is the germline BRCA status and what is the androgen receptor status? And start to divide the heterogeneity of TNBC into buckets right at that first line setting.
Yeah, real nice. How about you, Claudine?
I would echo what's being said. Obviously, we're looking at immunotherapy as well, and we'll get to that in a few moments. Just to go back to Hope's presentation from the CLGB trial, overall, we remember that trial. It was trying to look at ixabiplone versus Nab-Paclitaxel versus Paclitaxel, and overall, the take-home message from that trial was that Paclitaxel was better. What she presented that was interesting, and again, these were exploratory analysis, so we need to be careful, but it looked like if you looked in the triple negative subset, that the Nab-Paclitaxel might be a bit better, whereas in the ER positive, it was the Paclitaxel that was better. So, I think what it does is it tells us that that is an active drug in that patient setting. And the dose as well in that CLGB trial is not a dose that we typically use. So the toxicity data, I don't think reflect what is the more common use of the Nab-Paclitaxel. But again, those were subset analysis, but another interesting point to just tuck away there.
Yeah, that's right. It's a tuck away point, and it does, it reminds me of the tenacity data a little bit, which Denise Yardley, I believe, has just recently published. I think it came out. It was the frontline triple negative metastatic setting. In other words, if you have to pick a doublet because somebody's really got visceral crisis or very, very ill, you got to pick a doublet. Which doublet do you go to? Is it a gem carbo? Is it a Nab-Paclitaxel carbo? Or is it a Nab-Paclitaxel gem? Paclitaxel carbo was not in that trial, okay? But the clear winner on the PFS was clearly the Nab-Paclitaxel carbo at about 7.4 months versus about 5 months for the other. Was stat sig, no difference in survival. Well tolerated, certainly on a day 1, day 8 regimen, quite well tolerated. So. Again, no comparison to the Paclitaxel there, so we really don't know. But that particular doublet was the winner, and it's just interesting is the Nab-Paclitaxel coming up in the metastatic setting in the triple negative is potentially better than Paclitaxel. We've seen similar data in the preoperative setting too from Gephardt-Sixto, where the pass CR rate was higher with the Nab-Paclitaxel over Paclitaxel in the triple negative. It's a head scratcher, isn't it? It's a little bit of a head scratcher, isn't it? But it's just interesting. It's like one of those tuck away deals. And the only other point that I would make is that from the kind of triaging we do in the beginning is I just try not to miss what I call the Isikoff patient, the person that I could potentially cure, first line metastatic, triple negative, that 11%. I use the cis because cisplatin had double the long-term, durable CRs than the carbo in that parenchymal lung, lymph node, breast. It was not your bone livers. Your bone livers were not in that winner's circle, if you will. It was parenchymal lung, not pleural effusion, lymph node, or in breast disease. There's a small percentage that get the cures. So I try not to miss those patients there.